have everyone. What a large crowd. It's absolutely wonderful. And we're very pleased to have our guest speaker, Dr. Zalan. For the past 30 years, he has been and continues to be an anesthesiologist and an intensive care physician. He writes a column in the Northern Life on healthcare issues from time to time as well. Dr. Zalan is the past president of the medical staff at HSN and currently a member of the hospital's ethics committee. He's also involved in Health Sciences North project to improve decision-making with respect to health issues. He is here today to explain how he believes it is all about better communication between patients, families, and physicians. And to his, after his speech, we do have a little handout for you for further information as well. So please help me in joining you to welcome Dr. Zalan.
Thank you.
Okay. Photo wall.
Okay. Hi.
Fantastic, thank you.
Okay. Hello. Thank you. And let me just get my notes, and thank you for the introduction. And so I have to sort of read my notes. I'm not good at memorizing pages of stuff. I guess as we get older, we get less good at memorizing things. Anyway, so this talk is, can you hear me okay?
I'm just going to raise it just a little bit. How's that? Just a little bit. Just stand closer, Peter. There we go. How's that?
Like that?
Yes.
Can you hear me okay at the back?
Yes.
Okay. So this talk is about advanced care planning, and I come at my interest in this subject as a physician, as Brenda said, who's looked after patients in Sudbury's intensive care units. I spent many hours talking with families about plans for their loved ones. That's actually a good portion of the work. All along, I believed that there had to be a better way than having these difficult conversations when the patient could no longer participate in the midst of a crisis near the end of life. So the importance of advanced care planning is finally gaining recognition. It's been quite a while. I recently attended the 4th biannual meeting of this is a mouthful, of the International Society of Advanced Care Planning and End-of-Life Care. And so the society is pretty new. It was in Banff, and actually at the beginning of September. It was established in 2010, and presenters came to Alberta from Australia, New Zealand, Holland, Germany, Singapore, the US, Norway, Japan, England, and Canada. So it's getting to be quite a topical subject. Alberta initiated a province-wide policy on ACP in 2014. So what exactly is advanced care planning? And in the interest of brevity, I'm going to call it ACP. Acronyms are really in. ACP is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal is to help ensure that people receive medical care that is consistent with these values, goals, and preferences during serious and chronic illness, ensuring that when the time comes that the patient is no longer able to make his or her own decisions, the families and healthcare providers will be prepared to make decisions based on a firm understanding of the patient's values and preferences. So these ACP discussions should be considered as part of routine practice, not anything extraordinary, in the care of patients who have a chronic disease or serious illness early in the course of chronic illness and serious illness, sometimes years before the need for palliative or end-of-life care. It was always thought that you should start thinking about these things near the end of life. Early dementia is actually an excellent example. Early in the disease, the patient is still able to state his preferences for the time when he or she will no longer be able to do so, and death may be 10 years later. So the most valuable outcomes of ACP conversations are designation of a substitute decision maker, whom I will call the SDM, including who you do not want to be involved. We often saw families come from far away who hadn't seen their loved ones in a decade and then insisted on telling us what exactly we should be doing for their family member. Documentation of the designated SDM, a full discussion with your SDM about your goals and preferences, and ensuring that the documentation is available at times of need. Ontario law actually will designate the SDM for you if you do not. But this person may not be the individual that best understands your goals, values, and preferences, and whom you wish would make decisions on your behalf. If done well, more individuals would have the opportunity to die at home or in a hospice instead of the large numbers that are now dying in hospital. There will be improved quality of life in the time remaining. But there are barriers to overcome. So one of the big challenges is physician reluctance to talk about end-of-life preferences until all curative options are exhausted. They do not recognize that ACP is appropriate for any adult with decision-making capacity. Some data for you. Figures, 18% of physicians are comfortable in talking about ACP, 35% do it but are not comfortable, and the rest never do it. Conversations should discuss benefits versus burdens, not just the risk and benefit that many physicians are used to providing patients. Physicians believe that it is the patient who should start the conversation, while patients think it should be the doctor. So that makes for a bit of a conundrum. So nobody starts the conversation. Each person is waiting for the other. It would be useful to discuss the patient's ability to function at home rather than providing estimates of life expectancy. Time is such an unpredictable affair. Patients often want conflicting outcomes, wanting a good quality of life in the time remaining, but also living as long as possible. And sometimes they need to make a choice because the two don't exist simultaneously. Patients are also often poorly informed about their health, making it difficult to make an informed choice. 1/3 of folks in nursing homes are no longer competent to convey their wishes. So think about who would most benefit from an ACP conversation that you know, yourself, a loved one, a good friend. Indications for ACP include repeated use of the healthcare system, increasing frailty, multiple chronic diseases, multiple falls, the possible loss of competency in the near future. So these give you an idea of when it might be appropriate to start thinking about this. So let me take a step backwards to give you a historical perspective. Now this is really going back in 1871. 4 years after Confederation, only 3.6% of the population was 65 years of age or older. So we are a pretty young society and there were not too many seniors around. The life expectancy of Canadians at the time was 40, and only 1 in 3 people reached the age of 65. So this meeting probably didn't exist in 1871. Today, life expectancy is over 82, and 9 in 10 people can expect to reach 65 years of age. The recent increase in the number of seniors was the largest observed since 1871. We just had a census that came out last year. And the number of people aged 85 and older grew by 19.4%. Just think about that, 19.4% increase in 5 years. So just think about the next 5 years. Centenarians, that's people over 100, were the fastest growing age group. Pretty amazing. They went up by 49%. Canada's Medicare system was designed in the 1960s when Canada was still a young society. Physicians could offer relatively little then in the face of serious illness, but now we can offer much. I've witnessed since I graduated from medical school the nonstop increase in the power of medicine, be there surgical procedures, drugs, chemotherapy, diagnostic and imaging technology, or the application of mechanical devices. It's interesting, when I first arrived in Sudbury, that was in 1982, we just installed our CT scanner. Because now we have MRI, we have a second CT scanner, there's a PET scanner that's coming, and we would like a second MRI. When I finished my training, the treatment for a heart attack was bed rest, oxygen, and morphine. And now you rush to the catheterization laboratory 24/7 to see if it's possible to open up the circulation to a blocked coronary artery. We can implant pacemakers and defibrillators. Most recently, we can implant a small mechanical device as a bridge to cardiac transplantation. These innovations may prove very beneficial, and often do, but can also bring unintended consequences. Procedures have been applied to patients without taking into consideration the functional, emotional, psychological, and social needs of the patient, without considering the needs of patients who are medically complex, beset with a number of comorbidities, and are frail. Some may be approaching the end of life. For others with a diagnosis such as dementia, congestive heart failure, and chronic obstructive lung disease, life is getting more difficult, but death may still be a number of years away. For such patients, there's great value for difficult conversations prior to initiating medical interventions. Traditional health assessment focuses insufficient attention to physical function, mobility, mental function, and the cumulative weight of multiple chronic diseases and illnesses. Healthcare decisions then may be made in response to a single issue rather than considering overall health. And part of the problem with medicine is now we have all kinds of specialists, like I'm a specialist myself, so we got really to know a lot about one part of your body, but not that much about other parts. And you like to be a whole person as opposed to a bunch of parts. So I use the term frailty. What exactly is frailty? Frailty is a state of health that makes people vulnerable to illness and injury because they lack the strength to withstand physical and emotional stress. They possess a diminished ability to fight back to health. They may feel less stable on their feet, have a tendency to falls, and begin to move more slowly. They may find that shopping and housework are getting more difficult. As their ability to think and remember decreases, they may find it harder to keep track of the details of their daily lives. So during hospitalization or following medical procedures, frail patients may suffer complications such as delirium and functional decline. Delirium, I'll call a form of confusion, once triggered, may not fully resolve. Functional decline is the loss of the ability to perform tasks that the person could previously perform. The outcome may be dependency on others. It may mean being admitted to a long-term care institution, and these are very significant potential complications and burdens for an older individual. Aggressive treatments applied to frail individuals may lead to such outcomes. Nevertheless, many older individuals with advanced and incurable diseases receive highly aggressive treatments without discussion of these potential burdens. So I'll tell you about a 2014 study from Alberta, which actually looked at how frail patients did after a stay in the intensive care unit. So even though most people survived their ICU stay, and as an ICU physician, we thought that people who actually were able to be discharged from ICU alive, that was a success. So from our perspective. But only 15% of patients who had lived independently prior to illness were still living independently in follow-up a year later. We don't see our patients a year later, but people are starting to study this. So even as the power of medicine has made so much more possible, discussion between healthcare professionals on the one hand and frail, complex patients and their families on the other is too often insufficient to make informed decisions about treatment plans. Patients are often unaware of illness severity and of their limited life expectancy. So thus the most important first step to facilitate realistic decision-making is to clearly communicate information about current medical conditions, expected health trajectory, and prognosis. This transfer of information puts the patients and families in the proper position from which to apply their values and goals to reach an appropriate decision with respect to future treatment. And this process is supported by evidence that most individuals do want information about their medical condition. And that providing such information does change decision making. So consider the following findings published in the medical literature about communication. A 2013 American study documented an increase in the use of intensive care, repeat hospitalizations, and transfers of patients between facilities, such as from a nursing home to acute care at the end of life. Transfers to a hospice was an add-on after the failure of regressive care, such as chemotherapy, surgery, or care in the ICU. So the hospice was only considered after everything else failed. Most significantly, the nature of practice varied dramatically among American hospitals. The percent of cancer patients admitted to an ICU during the last month of their life, so this is at the end of their life, was 50% in the Detroit hospital and 9% in a renowned cancer hospital in Manhattan. So you ask yourself, why such variance in practice? The speculation is that it's the quality of the decision-making process prior to the treatment that accounts for a lot of the variance among institutions. High-quality, person-centered care at the end of life means that the patient defines his own path, or hers, through shared decision-making, often disproved not to be the case. So in an audit of, to move to Canada, in an audit of communication practices in 12 hospitals in Canada, published recently in 2016, the authors interviewed patients and family members shortly after hospital admission to determine their perspectives on the level of communication with healthcare professionals. The authors found that there was very little effective communication with members of the healthcare team about their goals of care. A 2009 US study looked at patients who had longer than a 21-day stay of use of a mechanical device to help them breathe in an intensive care unit. So they were attached to a machine that was doing the breathing for them because they were in respiratory failure. And they've been there now for 21 days, so this is a serious illness. Only 26% of their families reported that physicians discussed what to expect regarding the patient's future survival, general health, and caregiving needs. In another study, 2/3 of terminal cancer patients reported having no discussion with their doctor about planning for the end of life. And these are terminal cancer patients. So if you're not tired yet, I have another study. A 2012 study published in the New England Journal of Medicine asked nearly 1,200 patients with lung or bowel cancer, cancer that had spread to other tissues, whether they expected their treatment to cure them. Now these conditions, once these cancers have spread widely, have a poor outcome regardless of therapy. The authors found that the majority of patients felt that their treatment course was likely to cure them. Were these patients who were surveyed not told that their disease was incurable? Were they not told clearly? Did they choose not to believe the message? So what was going on that they thought they were curable? Direct observational studies indicated that only about 1/3 of the doctors actually stated the prognosis at any time. Half of the patients have not heard any of their doctors use the word hospice. We can only conclude that the quality of communication between healthcare providers and their patients left a lot to be desired. Do you have a glass of water, by any chance? If you don't mind. The current approach to medical training is a challenge. Too often, care is focused on attempting to cure the presenting problem to the exclusion of the patient's other needs. In other words, treating the disease instead of the patient. So that's where I was talking about us being specialists, that we know how to look after a particular disease, we've diagnosed it, and here's the treatment for it. But it's the disease that we're treating, not the person. While this model of medical care is appropriate for active, healthy individuals with an acute illness, so take a 25-year-old with appendicitis, the same approach for complex patients with multiple chronic illnesses often ends badly. The pressure on doctors at the moment remains all in one direction, towards doing more because it may save a life. This is actually how we're trained, and we're still trained this way. So I'll give you some case studies. Thank you. Okay. There, I can talk again. Mr. Smith is an 82-year-old gentleman with a history of moderate dementia, kidney dysfunction, and congestive heart failure. So he's got a number of problems, who lives at home with his wife. He ambulates independently with a cane and has had no falls in the past year. He gets short of breath when walking up a flight of stairs, but enjoys daily outings with his wife and spending time with their grandchildren. Workup of a solitary lung lump discovered incidentally in a chest x-ray when the patient had pneumonia revealed lung cancer. So as such, Mr. Smith underwent resection for cure, but his hospital course was complicated, unfortunately, by confusion and agitation that did not fully resolve. He was unable to return home and required admission to a long-term care facility. So although surgery was done with curative intent to preserve Mr. Smith's quality of life, surgery turned out to be the wrong choice for this patient. And the decision about surgery should be made in context of the patient's overall health, not just in reference to the lesion. A second case. Joan was in her 40s when her doctor delivered the bad news. She was terminal with cancer, only 40 years old. Yet in the eyes of her well-intentioned healthcare professionals, she was too young to give up. The proposed treatment plan was experimental chemotherapy because the regular chemotherapy had proved ineffective. Now, Joan lived alone with little family support. Further, the earlier chemotherapy had induced mental changes. Nonetheless, chemotherapy was initiated. It was not successful. Although she early on expressed the wish that she did not want to die in hospital, she spent her last 2 weeks of life in a hospital ward where the routine noise and bustle kept her agitated with frequent panic attacks, a poor ending to a young life. So what are the approaches that physicians take and have taken with their patients? Historically, we were paternalistic. We aimed to ensure that the patient received what we believed was best for them, and this is the doctor knows best model, like Dr. Kildare, Marcus Welby, and TD doctors from the 60s, and I don't know if you watch those guys. The second type of relationship is termed informative, where physicians tell you the facts and the figures. So here's what the red pill does, here's what the blue pill does, which one would you want? In truth, neither type of relationship is what many people desire. Patients do want information and do want control of their destiny, but also seek guidance. So this last type of relationship is called interpretive. We want physicians who are neither commander nor technician. The doctor's proper role is to guide his and her patients through shared decision-making. So recent evidence points the way to a coordinated, systematic model of advanced care planning. Oh, you brought me back some more? Oh,
no.
My goodness.
It just makes it easier.
This is great service. Thank you. You have a good president. A study from Australia published in 2010 used trained facilitators to identify the patient's wishes about end-of-life care. Conversations focused on values, not specific treatments. The research demonstrated that such an approach improves care from the perspective of the patient and the family, and diminishes the likelihood of stress, anxiety, and depression in surviving relatives. This approach also decreased unwanted investigations, interventions, and treatments, decreased hospitalizations, and admissions to critical care. So what's happening now in Canada and elsewhere with respect to advanced care planning? And this is what I discovered at the meeting in Banff. Alberta has province-wide policies and goals of care orders since 2014. There's provincial education for healthcare providers, and the province has developed a strategy for making paper forms available while evading a community-wide IT solution. Patients get a distinctive, readily identifiable package that contains their plans, called the green sleeve. There's widespread use of ACP in long-term care and assisted living sites, less used to date in acute care hospitals. To evaluate the usefulness of ACP, provincial chart audits and patient family home surveys were conducted. Alberta actually has a website that provides information to patients and families, which includes a guidebook in 7 languages and videos on YouTube. And the intent is to increase public awareness and education. In British Columbia, they're educating all healthcare providers in serious illness conversations, whether these occur in hospital, home care, or long-term care settings. Now, unfortunately, Ontario does not have a provincial policy or funding. However, individual institutions are encouraged to and are undertaking initiatives. For example, Sunnybrook Hospital in Toronto, and actually Health Sciences North here in Sudbury. There is a provincial website called Speak Up Ontario, which provides information for the public. In Germany, trade facilitators will be going out to family practices and nursing homes with funding provided by the government to discuss advanced care planning with patients. And programs also exist in selected jurisdictions in Australia, New Zealand, Holland, and the United States. So right now, I'll turn to the project at Health Sciences North, which began in January of 2016 and is slowly growing. The work clerk identifies all patients 85 years old and greater on 8 North, a mixed cardiology medical unit. A meeting with the patient is scheduled early in the mission. It tries to include a family member. If the patient is uncertain about his or her medical condition, the attending physician is consulted, and there may be a consultation with a social worker to get more information. And when all this information is documented, it goes into the electronic medical record or the chart if there's no EMR. So it's all about asking the patient a series of questions, and I'll read you the questions that are actually asked. So first, based on previous discussions with healthcare providers, what is your understanding of your illness? Do you expect to get better, to be cured? Is your illness expected to get worse over time? And as I noted, this is very important because the majority of patients actually underestimate the severity of their illness and infirmity. Second, do you think that you need to know more about your condition? Is there information about your illness that actually you do not want to know? 3, what do you value? What is important in your life that gives it meaning? For example, being able to live independently, being able to recognize important people in your life, being able to communicate, being able to eat and taste food, spending time with family and friends. 4, what worries or fears come to your mind when considering the end of life? For example, struggling to breathe, being in pain, being alone, losing your dignity, being a burden to your family and friends. 5, if you were to develop a critical illness, life support might be offered to you in an intensive care unit. What would you be willing to trade for the chance of gaining more time to live? Would the burden of certain treatments, for example, living in an intensive care unit on machines, getting nutrition through a tube, be acceptable to you if there was even a slight chance of gaining more time? 6, if you understood that you were near the end of your life, what might make the end more meaningful or peaceful for you? For example, family and friends nearby, dying at home or in a hospice, having spiritual rituals performed, listening to music. So these are the questions that we're asking. Most patients were very open to having a values-based conversation about what is important to them in life, the ones that we surveyed after we started. Now, this program has now spread to the dialysis program, the congestive heart failure clinic, and the City of Lakes Family Health Team. We're also developing a teaching program at the simulation laboratory using role-playing and scripted scenarios to teach healthcare providers how to conduct these conversations. And there are also many tools now available on the internet for the public to become knowledgeable. You can study online, download pamphlets, watch videos, and then take that knowledge to your physician and initiate the conversation. If you think advanced care planning may be approach for you, for a family member, for a friend, then I would urge you to investigate these sites. Arrive knowledgeable at your physician's office and initiate the conversation. And I've prepared a handout, which is there, I think, on the table, which has two excellent websites that are definitely worth looking at. So that's the end of my presentation, but I'd be happy to answer any questions, listen to comments. Thank you.